Hello and welcome to lectures on cardiac morphology and congenital heart disease. This video is on conotruncal anomalies part 2, and that includes transposition of the great arteries and corrected transposition of the great arteries, or CCTGA. So here we will see short axis view and forward chamber view. And next we will see a complete transposition of the great arteries with an intact ventricular septum. Next, a complete transposition of the great arteries with pulmonary stenosis and a ventricular septal defect. Next, we will see a complete TGA with an intact ventricular septum after the arterial switch operation with LV failure. Then we will see samples of corrected transposition of the great arteries with VSD and pulmonary stenosis. Corrected transposition of the great arteries with an Epstein anomaly of the left-sided tricuspid valve with a ventricular septal defect. Corrected transposition of the great arteries with atresia of the right-sided mitral valve and a pulmonary artery banding. And finally, we will show you 3D printed heart models of a corrected transposition of the great arteries with ventricular septal defect, pulmonary stenosis, and aortic stenosis in an adult. So let's go ahead and get started. The first specimen is a 4-chamber section of a normal heart. So if we open, we will see the posterior aspect of the heart. So this is the right atrium and the right ventricle, and that's the tricuspid valve. And this is the left atrium, mitral valve, and the left ventricle. Now, if we put the anterior part of the heart, we'll see that this is the right ventricle, and this is the right ventricular outflow tract pulmonary artery, and this is the left ventricle going to the aorta in that way. So we can see the outflow tracts are in cross section to each other, and that's the normal relationship. So if we look at the atrial arrangement, it is situs solutus for the atria, so the right atrium on the right here and the left atrium on the left. And the right ventricle is on the right, so it's also a normal looping, a D loop for the ventricles. And the aorta is posterior and to the right, which is also the normal arrangement or situs solutus for the great arteries relationship. So atrial situs, D loop ventricle, and situs solutus for great arteries. So this whole arrangement is the normal arrangement for a normal heart. If we correlate this with this short axis cuts, we see the same thing. Let's look at 2 separate cuts in the upper panel, which is the more superior cut. This is the right atrium, and this is the tricuspid valve, which is right here, the tricuspid valve, and the right ventricle and the pulmonary artery. And here we can see the left atrium, mitral valve, which is right here, and then opens into the aorta right there, and in crossing relationship as well. So that's the normal heart and the normal arrangement for a normal heart. So let's take a look at this next specimen, which is an abnormal heart. Here we see let me show you the right side of the heart. This is the right atrium connected to the right ventricle, but the right ventricle gives rise to an ascending aorta and an aortic arch. And the left side, let me get closer here, maybe you can see it better. This is the left atrium connected to a left ventricle that gives rise to a pulmonary trunk. So the situation is the systemic venous return come back to the right ventricle, to the aorta, this way, and then the pulmonary venous return comes from the lungs to the left atrium, to the left ventricle, and to the pulmonary artery this way. So the 2 circulations are, instead of being in series, they are in parallel and not mixing. So it is crucial to have a mixing area, channel, communication between these 2 circulations, which is usually the atrial septum right here. So if this communication is small, it can be enlarged either by atrial septostomy or septectomy to create the mixing that is necessary to keep the patient alive. Now, if we open the heart and we look at the ventricular septum, we see that there is no ventricular septal defect to create an additional source of mixing. So this is an intact ventricular septum in the setting of a transposition of the great arteries. And to treat this surgically, the surgeon performed an arterial switch, moving this aorta to the pulmonary artery and the pulmonary artery to the aorta, known as the arterial switch operation. It is not unusual to have an associated anomalies with the transposition of great arteries lesion, as in this heart. So here we have right atrium to right ventricle that gives rise to an ascending aorta. And on the left, the left atrium, pulmonary veins to left atrium, draining into the left ventricle, that's given rise to the pulmonary artery. So this is transposition of the great vessels. However, if we look at the septum, we see that there is a ventricular septal defect right there. So this ventricular septal defect is important to provide an additional source of mixing between these two pulmonary and systemic circulations. And in this particular setting, we can see that in the pulmonary valve, there's significant stenosis right there. And that stenosis actually helps the patient and helps directing more oxygenated blood flow through the ventricular septal defect into the right ventricle. So it goes from here into the right ventricle, and it adds to the oxygenated blood going to the rest of the body. So this actually helps the patient, and it can also help in delaying the surgical repair till later. Although that the associated lesions can complicate the normal arterial switch operation due to the addition of these two extra lesions. So that's TGA with pulmonary stenosis and VSD. And that brings us to the next specimen, which is a successful switch operation in a patient with transposition of the great artery. So here's right atrium, and this is right ventricle, normal arrangement. And the right ventricle was connected to an ascending aorta previously. And on the left, we see the left ventricle connected previously to a pulmonary trunk. After the arterial switch operation, the pulmonary artery now is sitting and connected to the right ventricle anteriorly, as you can see. And the aorta was translocated and moved posteriorly to be connected to the left ventricle. You can see the aorta behind it. And that's the pulmonary artery where it is right now. So the major challenge in this situation, as you know, is translocating the coronary arteries along with the great arteries. And in this situation, the patient, after the successful switch operation, had a left coronary flow compromise that caused, as you will see here, ischemic changes in the subendocardial area. So this ischemia caused left ventricular failure, which eventually caused the death of the patient. Look at this discolored subendocardial area caused by the compromised coronary flow. Now let's move to another set of hearts of corrected transposition of the great arteries. So here we have a specimen that is different from the previous. Here we have the right atrium on the right side connected to a morphological left ventricle on the right side. Look at the trabeculations, the smooth trabeculations of the left ventricle, and the mitral valve morphology of this AV valve. So this is a left ventricle on the right side. So we have right atrium connecting to a left ventricle on the right side. So AV discordance, atrioventricular discordance here. And now if we open up the outflow tract, we see that the left ventricle is connected to a pulmonary artery. So again, ventriculo-arterial discordance, ventriculo-arterial discordance. So it's a double discordance. Now, if we look at the left side, we see the left atrium, morphologic left atrium on the left, and that is connected to a morphologically right ventricle on the left. Note the morphologic left ventricle with the typical tricuspid valve, and this is connected to a aortic arch. Look at the typical subaortic infundibulum, which is separating the aorta from the right ventricle, and that's one feature of the right ventricle. Look at the attachment of the tricuspid valve to the septum. So let's review the blood flow in this case. So we have a right atrium connected to a left ventricle on the right side, which is connected to a pulmonary artery, and a left atrium connected to a right ventricle on the left side connected to the ascending aorta. So the venous blood flows from the right atrium to the pulmonary artery normally, and the pulmonary venous blood flows normally from the left atrium to the ascending aorta. So physiologically, the two circulations are in series and normal. So if there are no associated anomalies with this lesion, the flow can be completely normal. However, usually there are associated lesions to make things complicated. So in this particular case, the associated lesions are a ventricular septal defect. If we open this right ventricle here, let me show you the internal arrangement again. So we can look here and see a ventricular septal defect and pulmonary stenosis. The combination of these two lesions will make things complicated and probably shorten the lifespan of these patients. So ventricular septal defect and pulmonary stenosis in the setting of corrected transposition of the great arteries. There are other associated anomalies, more commonly an Epstein anomaly of the tricuspid valve on the left side. So here we have a right ventricle on the left, and if we look at this tricuspid valve, we can see that it is not in the normal location right here. Look at this downward displacement of the septal leaflet and the plastering to the septum, and this is not uncommon finding in corrected transposition of the great artery. Another finding in these patients is conduction disturbance. Since the AV node is intimately related to the atrioventricular membranous septum and the ventricular looping here is reversed, so there will be some conduction problems related to the abnormality of the conduction system. Okay, let's take a look at this last specimen of corrected transposition. Here we have right atrium to left ventricle on the right side and pulmonary artery coming out, and the left atrium to right ventricle and an aorta. I want to show the relationship of this aorta. Look at it, it's anterior and to the left, which is the most common type of relationship of the aorta to the pulmonary artery. So the aorta is anterior to the left, and the pulmonary artery is posterior and to the right, which is usually stenotic, but in this case it's not. So a band was surgically placed here, as you can see, to create the restriction of flow to the lungs. Okay, so we will end this session with a bang, as they say, as this is the last specimen. It's not a live real specimen, but it's a 3D printing of a patient with congenital corrected transposition who is still alive and not operated. So this is SVC. This is right atrium draining into a morphologic left ventricle on the right, as you can see the smooth shape. This is the pulmonary artery coming out from this left right-sided ventricle. This is the left atrium. This is a morphologic right ventricle on the left, giving rise to the aorta. And here you can see a VSD that is present with this patient. However, there's some subpulmonic stenosis that and also subaortic stenosis that caused them to be balanced somehow and remained unoperated until now. However, if you look at the pulmonary artery, look how the pulmonary artery is dilated, indicating that the patient has pulmonary hypertension as a result of the long-standing lesion that he has. And that makes the issue a little bit challenging, the surgical repair, as when to do it and how to approach it at this age. So this is a sample of a real patient who is now 40 years of age that is still living unrepaired. So I hope you enjoyed this session, and we'll see you in our next videos. Thank you for watching.